handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hi, so it's me again, and today let's talk pathology. And I think we have to start with the heart, and here's a rough outline of our discussion. Today we'll talk about, albeit a pretty fast or concise version of everything. Our goal here is tackle the most high yield points in um, in specific topics. So we have the heart for today. Heart, uh, white blood cells, red blood cells, bleeding, etc. So anyway, let's talk about the heart first. And a rough outline would be here: congenital heart disease, ischemic heart disease, arrhythmias, hypertensive heart disease, valvular heart disease, cardiomyopathies, congestive heart failure, and cardiac tumors. So again, no, concise lang tayo. So let's start with congestive heart disease. Now, we can classify, we can classify our congenital, no, uh, that's an error. We can classify our congenital heart disease into left to right shunts, right to left shunts, or obstructive lesions. Now, first, we talk about left to right shunts. Now, left to right shunts, usually you have a congenital heart disease that increases blood flow into the pulmonary circulation. So, when we say left to right shunts, from the left heart, systemic, no? Systemic is left, right is pulmonary. So, kapag may butas sa puso mo that makes blood go from the left side of the heart, which is systemic, to the right side of the heart, which is pulmonary, that's a left to right shunt. No? Kapag nasa right heart, remember, the right heart, right atrium, right ventricle will pump blood to the pulmonary circulation. That's why kapag left to right shunts, increase blood flow into the pulmonary circulation. No? Again, butas yung heart, yung blood sa left pupunta sa right side, yung right side ipapump yung blood sa pulmonary circulation. Increase blood flow into the pulmonary circulation. What will happen? So what will happen if blood flow is increased into the pulmonary circulation as with left to right shunts? So our pulmonary circulation is usually low pressure and low resistance. Remember, we are just perfusing the lungs, no? Unlike our systemic circulation, usually high pressure, higher resistance. No, in the lungs, we really don't need that kind of pressure and resistance. No, so the pulmonary circulation is usually low pressure and low resistance. Now, what will happen if you increase blood flow to that usual low pressure and low resistance pulmonary circulation? You will have increase in pulmonary resistance and what do you call that? Pulmonary hypertension. So, pulmonary hypertension. Now, if you have pulmonary hypertension, your right ventricle, kailangan niya i-match, no? Or at least kailangan mas malakas yung pressure na pinapump ng right ventricle into the pulmonary circulation, no? Para ma-overcome niya yung pressure na yon, ma-perfuse niya na maayos yung lungs. You have the right ventricle has to overcome that pulmonary hypertension. So, to compensate for that, kailangan niya lakasan yung pump niya. To compensate for that, you will have right ventricular hypertrophy. No? That's a stress, no? Stress siya sa puso, no? Right ventricular. It will cause right ventricular hypertrophy. Think of it this way, no? Our muscles, skeletal muscles, um, you put your muscles in stress. Let's say nag-gym ka, nagbubuhat ka, okay? So what will happen? Your muscle will adapt to that stress, di ba? So lalaki sila, mag-hypertrophy. Ganun din sa heart. Now, in this case, may pulmonary hypertension ka, your right ventricle has to overcome that pressure, and the adaptation would be hypertrophy. No? So remember your adaptations, no? Hypertrophy, hyperplasia, etc. No, that's not really part of our lecture. So, right ventricular hypertrophy could be beneficial until to the point na magkakos na siya ng right-sided heart failure. How? No, how? Usually, kapag magkakaroon ka na ng hypertrophy sa chambers mo, no, especially sa ventricles, you will have decrease in diastolic filling leading to heart failure. Now, that's the right ventricular hypertrophy in left to right shunts. Now, pulmonary hypertension. So, you have increased pressures sa pulmonary circulation mo. So, syempre, babaliktad din, no? Mataas ang pressure sa pulmonary circulation mo, tataas, babaliktad. Tataas ang pressure sa pulmonary arteries, tataas ang pressure sa right ventricle, tataas ang pressure sa right atrium. Now, if the pressure sa right ventricle, remember may butas ka sa puso, ha? If, if the pressure sa right ventricle maging mas mataas sa pressure ng left ventricle, what do you think will happen to the blood? Diba? How does blood flow? How does fluid flow? No, fluid mechanics. From high pressure to low pressure. Normally, mas mataas ang pressure sa left ventricle than the right ventricle. Kaya usually left to right yung shunt. Now, may pulmonary hypertension ka, mataas yung pressure sa pulmonary circulation, bumaliktad, tumaas ng pressure sa pulmonary artery, tumaas ang pressure sa right ventricle, sa right atrium, naging mas mataas yung pressure sa right ventricle mo, naging mas mataas siya than the left ventricle, what will happen? The shunt will be reversed. Okay? The flow na normally, no, sa left to right shunt, left to right, kasi mas mataas usually ang pressure ng left to right, high pressure to low, naging mas mataas si right because of the pulmonary hypertension, shunt reversal. Right? Since mas mataas na yung pressure sa right ventricle, it will now push blood from the right to the left. No? Now, sa right side of the heart, hindi pa siya nakakapunta sa pulmonary circulation, right? Diba? Galing siya sa systemic circulation. What do you think will happen? Ano ba yung blood sa right side of the heart? Is it oxygenated or deoxygenated? Deoxygenated. Now, your deoxygenated blood sa right pupunta sa left. Your left will pump that deoxygenated blood sa systemic circulation. Walang oxygen, that will cause cyanosis. What do you call that? Shunt reversal. That is your Eisenmenger syndrome. Okay? So, left to right shunts, syempre, madami tayong examples of congenital heart disease that can cause left to right shunting. So, particular examples would be ASD, VSD, and PDA. ASD stands for atrial septal defect. VSD stands for ventricular septal defect. PDA stands for patent ductus arteriosus. Not shown in the image is your patent foramen ovale. Now, your atrial septal defects and patent foramen ovale, those are the most common. Remember, most common congenital cardiac anomalies diagnosed in adults. Okay? In adults. Atrial septal defects for adults, no? Nadadiagnose usually sila in adulthood. Remember that, okay? Buzzword yon. Okay? Ventricular septal defects, These are the most common congenital cardiac anomalies at birth. Okay? Ventricular birth. Okay? Ulit. Atrial septal defects diagnosed in adults. Okay? A for A. Ventricular septal defects. V. Most common congenital cardiac anomalies at birth. Birth. Di ba? Okay. So, patent ductus arteriosus, no, usually that's the link between the pulmonary artery and aorta that normally closes after birth. Now, konting pearls, if you are, since wala pa naman tayo sa right to left, sa cyanotic, anyway, if you have cyanotic heart disease, no, usually the life-saving lesion, if tanongin ka, what's the life-saving lesion? In a patient with cyanotic heart disease, that's your patent ductus arteriosus. Okay? It allows oxygenated blood to be pumped throughout the systemic circulation. Pag wala kang patent ductus arteriosus, tapos may cyanotic heart disease ka, for instance, you have a transposition of great vessels, tigok. Okay? Now, let's move to right to left shunts. Okay? Right to left shunts. Now, in right to left shunts, hindi pumupunta ng pulmonary circulation yung blood mo, 'di ba? Galing systemic circulation, deoxygenated na yung blood, pumunta ng right atrium, pumunta ng right ventricle, o imbis na pupunta ng pulmonary circulation, it will be bypassed. Okay? Dadaan siya sa butas, no? Diretso siya sa left ventricle. Okay? Tapos pump sa systemic circulation. Okay? So, since hindi siya dumadaan sa pulmonary circulation, that blood will not be oxygenated. And if deoxygenated blood is pumped throughout the systemic circulation, that will cause cyanosis. Okay? Cyanosis. So, the most common cause of cyanotic congenital heart disease is actually your tetralogy of Fallot. Tetralogy, 4, no? Tetra pack. Apat yung core. Apat yung tetra, apat. So, pag tetra, merong apat na components. Di ko alam ba't pinaulit-ulit ko yung tetra. Anyway, pag tetra, may apat na components. We have your VSD, okay? VSD. We have your overriding of the VSD by the aorta. We have your right ventricular outflow tract. Okay, right ventricular outflow tract and right ventricular hypertrophy. Okay? So that's your tetralogy of Fallot. Now, if you're asked the severity of tetralogy of Fallot depends on which of the following as my choices. The right answer is the degree of pulmonary outflow obstruction or right ventricular outflow tract obstruction. Okay, so that's your tetralogy of Fallot. So, congenital heart disease yun. Cyanotic congenital heart disease, most common cause. Transposition of great vessels, no, another cause of your right to left shunting, no. So, the aorta rises sa right ventricle. So, right ventricle, deoxygenated blood, di ba? Tapos, ipapump sa aorta, systemic circulation agad. Cyanotic. So, paikot-ikot sa systemic circulation yung deoxygenated blood. Di ba? Tapos, yung pulmonary artery, it will arise sa left ventricle. Tapos, pulmonary artery, paikot-ikot sa pulmonary circulation yung oxygenated blood. So, that's futile. No? The transposition of great vessels is incompatible with life. Okay? A popular mnemonic, I think, no, or memory aid for cyanotic congenital heart disease would be 1, 2, 3, 4, 5. Tapos, puro T. T, 1, 2, 3, 4, 5. No? So, T1 is T1. One vessel, truncus arteriosus, no? T1. Okay? T1. One vessel, truncus arteriosus. Next na T2. Transposition of the two great vessels. Okay? T3, tricuspid atresia. T4, tetralogy of Fallot. Okay? Tetra is 4. And T5 is um, P5 is your total anomalous pulmonary venous return. O paano naging 5 yun? 5 words. Okay? Total anomalous pulmonary venous return. Okay? Ulitin natin, no? T1, 1 vessel, truncus arteriosus. T2, transposition of the 2 great vessels. Okay? T3, tricuspid atresia. T4, tetralogy, tetra means 4, tetralogy of Fallot. T5, total anomalous pulmonary venous return. Paano naging 5? 5 words. Alright, that's a popular memory aid for your right to left shunting. Lastly, congenital heart disease will can lead to obstruction, no? Mga obstructive lesions na obstructive congenital heart lesions. So this is the obstruction, congenital heart disease that leads to obstruction. Usually, it is characterized by the obstruction of blood vascular flow by the narrowing of the chambers, okay, valves, and major blood vessels. So if you have a malformation that is characterized by complete obstruction, that is known as your atresia. Okay, that's known as your atresia. And obstructive lesions, obstructive congenital heart disease lesion is exemplified by your coarctation of the aorta. So, coarctation of the aorta is a common form of your obstructive congenital heart disease. So, we have two forms of your coarctation of the aorta. We have the infantile and the adult form. Okay, infantile form usually that's the coarctation is between the left subclavian artery and a patent ductus arteriosus. That's the infantile form. Ang tawag natin dyan is the preductal form. Okay, preductal. Kapag adult, no, adult, wala tayong patent ductus arteriosus. Okay? It is usually caused by the infolding of your aorta to the ligamentum arteriosum. Okay? Ligamentum arteriosum is the remnant of your ductus arteriosus. So, that is postductal. Again, infantile is preductal. Okay, ito, di ba? Ito yung ductus. Di ba? Before the ductus, preductal, infantile. Adult, postductal, no? After the ductus. Actually, kasi wala nang ductus, ligamentum arteriosum na siya. Okay, pearls. In the infantile form, the right ventricle is hypertrophied. Okay? The right ventricle is hypertrophied. Bakit? Again, 'di ba pinag-usapan natin yung left to right shunting sa left to right shunting. An example of left to right shunt is your PDA. Tapos magkakaroon ng pulmonary hypertension, magji-gym yung the right ventricle is hypertrophy. So that's the infantile form. Adult form, left ventricle is hypertrophy. Bakit? So pag meron kang coarctation of the aorta, no, postductal, mataas yung pressure mo sa aorta, and the left ventricle have to overcome that pressure. So again, the left ventricle has to adapt, mag-hypertrophy. Okay? Reiteration, infantile form, right ventricle is hypertrophied. Bakit? Kasi may PDA. Okay? May PDA, meron kang left to right shunt. Adult form, the left ventricle is hypertrophied. Bakit? The left ventricle has to overcome the increased aortic pressures. Alright? Sige. So, next would be your ischemic heart disease. So, in pathology, so iba kasi ibang ischemic heart disease in internal medicine, ibang ischemic heart disease discussion in pathology, but parehas lang silang ischemic, no? Caused by decreased blood flow in your coronary arteries, no? So, we can classify your ischemic heart disease into angina pectoris, myocardial infarction, and chronic ischemic heart disease. Another classification niyan, yung pang-IM, is your chronic coronary syndrome and your acute coronary syndromes. Tapos in the acute coronary syndromes, magba-branch out into NSTEACS or non-ST elevation acute coronary syndrome and your STEMI, di ba? ST elevation myocardial infarction. NSTEACS will further branch out into unstable angina and non-ST elevation myocardial infarction. So that's another way to classify your ischemic heart disease. Okay? So in angina pectoris, pwedeng stable angina, Prince-Metal angina, or variant angina, or unstable angina. Usually, when we say stable angina, that's actually the spectrum of your chronic coronary syndrome. Otherwise known as your chronic stable angina pectoris, no? Pero mas bagong term natin is your chronic coronary syndrome. So, unstable angina, okay? Stable angina. Usually when we say stable angina, you haven't reached the critical point of your coronary artery stenosis brought to you by atherosclerosis. So usually, presentation of your stable angina um, would be chest pain, substernal, no? Radiating to the left, right extremities, pwedeng epigastric, pwedeng radiating to the lower jaw, okay? That is relieved by rest or nitrates. Then duration niya usually less than 5 minutes. Okay? Prince-Metal or variant angina is a type of angina that is not particularly caused by your atherosclerosis, but it is caused by your transient coronary vasospasms. So, in Prince-Metal or variant angina, usually we can see sa ECG changes, ST elevations. Okay? ST elevations. Pero, pag nahuli natin na nagko-constrict, habang na-ECG mo siya na habang nagko-constrict, no, yung coronary arteries mo. So, when we diagnose your Prince-Metal or variant angina, angiography talaga. Tapos kailangan mahuhuli mo na mahuhuli mo na nag-constrict no yung coronary arteries mo. Okay? Treatment niyan, pang IM na yon, no? Sa IM lectures nyo na. Pero usually, calcium channel blockers. Okay? Unstable angina, so nag-reach ka na ng critical point of stenosis, then usually meron ka ng acute event. That acute event is most commonly your plaque rupture. Okay? Plaque rupture. Usually, yung mga may acute event na yan, yung mga malala na yan, yung mga NSTEMI na yan. Okay? NSTEMI and STEMI. Sa unstable angina, ang pinagkaiba nila sa stable angina is that parehas pa rin naman yung chest pain quality mo, but usually the duration is more than 30 minutes, no, in some textbooks. Pero actually, more than 10 minutes, you suspect unstable angina already. Okay? Tapos, it is not relieved by rest or nitrates, or actually the pain is present at rest, no? Usually in angina, the pain is precipitated by effort. Okay? So, unstable angina yon. So, another form of your ischemic heart disease is your myocardial infarction. Dito na papasok yung NSTEMI mo and your STEMI. Okay? So, in myocardial infarction, barado na yung blood vessels mo, yung coronary arteries mo, hindi na makapasok yung blood sa heart. This will cause necrosis of the heart muscle resulting from ischemia. Okay, now, most myocardial infarctions are caused by acute thrombotic obstruction. So, usually, magra-rupture yung atherosclerotic plaque mo. It will cause a local thrombotic reaction, then will cause obstruction of your coronary artery. Okay? Due to rupture of your atherosclerotic plaque. Okay? Ngayon, if partial lang, okay, partial obstruction, that's your NSTEMI, non-ST elevation. So usually kasi hindi ka magkakaroon ng transmural infarction in your NSTEMI. When you say transmural, buo, all layers of the heart, no, buong-buo na infarction. Sa NSTEMI, usually hindi buo, no? Hindi it's not the full thickness of the heart yung affected. Usually it's the subendocardium only. Okay? Pero in STEMI, buo yan. Transmural yan. Okay? So, again, next. Now, usually, um, our our myocardial infarction, depende siya, no, sa blood vessels that are occluded, no? So, most commonly, it's still your left anterior descending na o-occlude. So, kapag left anterior descending artery yung na-occlude, usually that's an anterior infarction. Kapag right coronary artery yung na-occlude, usually that's an inferior, no, inferior infarction. If your left circumflex, no, yung left circumflex yung affected, that's your lateral, no, lateral infarction. ECG leads, no? Pag inferior wall obstruction, RCA, no, right coronary artery, yung ECG leads natin na magkakaroon ng ischemic changes, no? It's your 2, 3 and AVF. Okay? Kapag anterior, ano yung ECG leads na magkakaroon ng ischemic changes? Left anterior descending artery. Usually, that's your V1, sorry, actually V2 to V4, no? Pero V1 minsan nasasama yan kasi the septal wall is actually also supplied by your left anterior descending artery. Now, V1 is septal, V2, V3, V4, that's your anterior wall. Kapag V5 and V6, that's your lateral wall, no? So, kapag left circumflex yung barado, okay, lateral wall infarct, no? Your V5 and V6, magkakaroon ka ng ischemic changes. Sama mo na rin yung 1 and APL, that's the high lateral wall. Okay? Sige. So, konting pearls pa, no? Kapag infarction, usually that can cause decrease in heart rate or bradycardia. Ang tawag natin dun sa reflex na yon is your Bezold-Jarisch reflex. Okay? Bezold-Jarisch reflex. Kapag anterior wall infarction, usually magkakaroon ka ng increase in heart rate or tachycardia. That's your James reflex. Right? So, we have a lot of complications in your myocardial infarction. No? We have contractile dysfunction, papillary muscle dysfunction, myocardial rupture, arrhythmia, pericarditis, dilatation, ventricular dilatation, aneurysm formation, mural thrombus, and reperfusion injury. It makes sense, di ba? Contractile dysfunction. Magkaroon ka ng myocardial infarction, mamatay yung heart tissue mo. So, yung patay na heart tissue, would that contract? Hindi, no? So, contractile dysfunction. And that will eventually lead to heart failure. Okay? Papillary muscle dysfunction, no? Papillary muscle, yun yung muscle na nakadikit sa iyong valves. Siyempre, it's still supplied by your arteries. Now, if you have ischemia, no, of your papillary muscle, that can cause papillary muscle rupture. And usually, pwede ka magkaroon ng new onset valvular regurgitation, usually mitral regurgitation, no? New onset valvular regurgitation. Okay? Myocardial rupture. Pwede, magi-ischemia yung myocardial walls mo, mamatay. Siyempre, patay na yan, it is prone to rupture. So, pwedeng interventricular wall rupture, no? Pwede ka magkaroon ng new onset na VSD, okay? Or free wall rupture and can cause cardiac tamponade. Okay? So kapag meron kang new murmur, 'di ba? Pwedeng new mitral regurgitation murmur or new holosystolic murmur, 'di ba? You could suspect, no? Nagkaroon ng myocardial infarction, no? Okay, myocardial rupture, arrhythmia, no? Arrhythmia. So, syempre, arrhythmia, pwede pa rin, no? Pwede pa rin magkaroon ng arrhythmia in myocardial infarction, no? It can disrupt the the pathway, no? It can disrupt the pathway, conduction pathway, ayon. conduction pathway of the heart, no? Kapag meron kang infarct, and can cause several various arrhythmias. Lethal arrhythmias, definitely ventricular fibrillation, ventricular tachycardia, yung pulseless, no? Pericarditis, meron tayong dalawang klaseng pericarditis post-myocardial infarction. Yung isa is your acute onset pericarditis and usually acute, no? Few days after the myocardial infarction. Okay? Pangalawa is your Dressler syndrome. That's yung nag-aano, no? Pericarditis that yung onset niya is weeks after the myocardial infarction. Okay? So, ventricular dilation and aneurysm formation. Okay, so magiging scar tissue yung infarct mo, yung ischemic tissue mo, magiging scar tissue that can cause ventricular dilatation, magkakaroon ka ng ventricular aneurysm. So, magkakaroon ka ng left-sided or right-sided heart failure. Okay? Mural thrombus, since hindi na nagko-contract ng maayos yung heart mo, magkakaroon ka ng turbulence sa blood flow inside your chambers and can cause thrombus. So, pwede ka magkaroon ng cardioembolism. Okay? And of course, your reperfusion injury. Okay? Dami natin discuss Anyway, chronic ischemic heart disease is actually in Robbins, no? In your pathology, the definition of your chronic ischemic heart disease is ischemic cardiomyopathy, and that is your progressive heart failure due to cumulative myocardial damage. Okay? So, ito yung sinasabi ko na mas gusto kong classification for ischemic heart disease. So, ischemic heart disease, you can classify that into chronic coronary syndrome, tapos again, chronic coronary syndrome and acute coronary syndromes. Then your chronic coronary syndrome, meron siyang diagnostic criteria based on your clinical examination, no? Usually, normal ECG at rest, no? Magbigay ka ng stress, no? Mag-stress test ka, dun ka pala magkakaroon ng findings. So, acute coronary syndrome, of course, may events, di ba? Acute event, sorry. So, unstable angina, and STEMI, again, hindi transmural. Usually, subendocardial lang. Kapag STEMI, transmural infarct. Okay? So, ayun. Ayun. So, STEMI. So, how would you treat your STEMI? Of course, still your reperfusion. Reperfusion of choice natin is your primary PCI or your percutaneous coronary intervention, also known as your angioplasty. Okay? Usually, dapat less than 90 minutes, no, door to balloon time. If hindi available, no, you do your fibrinolysis. Okay? Fibrinolysis. Alright? Anyway, next is your arrhythmias, no, in your heart. So, we have different types of arrhythmias. So, madali lang siya. You just have to classify whether your arrhythmia is wide complex or narrow complex, no? So, actually, no, this is, may isa pa yung classification sa arrhythmia, no, especially in bradycardias, no? Pero, mas gusto ko to, no, wide complex versus narrow complex. So, narrow complex tachycardias, usually mga SVT, no, SVT. Sa mga wide complex tachycardias, usually your ventricular tachycardias. Ganun, no? So anyway, arrhythmias is not really a pathology topic, so I really would not spend a lot of time here. Anyway, let's go with hypertensive heart disease. Ito na, nag-gym ang puso, no? So, hypertensive heart disease, it can be systemic, left-sided, or pulmonary, which is right-sided, no? Actually, napag-usapan na natin to kanina, so let's just reiterate, no? So, left ventricular hypertrophy, no, secondary to documented hypertension in the absence of other cardiovascular pathology, that's your systemic or left-sided hypertensive heart disease. So, let's say, you have primary hypertension, mataas yung BP mo, mataas ang BP sa systemic circulation. Again, the heart, no, the left side, systemic tayo, left side, di ba? The heart has to overcome those pressures. So, kailangan mag-adapt. So, adaptation natin is hypertrophy. Left-sided hypertrophy due to chronic hypertension or chronic systemic hypertension. Same with your pulmonary or right-sided hypertensive heart disease. You have pulmonary hypertension. So, your right-sided pulmonary, di ba? Your right heart has to adapt, no, to those pressures. So, mag-hypertrophy yung right heart mo. So, that's your right-sided hypertensive heart disease. So, what are the causes? No, what are the causes of your pulmonary hypertension? So, napag-usapan natin kanina, one cause of your pulmonary hypertension is your congenital heart disease, yung mga left to right shunting natin. Pero meron pang iba, di ba? Diseases of the lung parenchyma, COPD, no? COPD, ang unique, no, sa pulmonary vasculature natin, sa ibang organs, usually, kapag walang oxygen, nagda-dilate yung blood vessels. Okay? Nagda-dilate ang blood vessels. But in the pulmonary circulation, if you have decrease in oxygen, your blood vessels will vasoconstrict. Bakit? No? Kasi gusto ng katawan natin, gusto ng lungs natin i-divert yung blood flow into the parts of the lungs that are more oxygenated. 'Di ba? So dun sa parts na lungs na less oxygenated, magko-constrict yung blood vessels natin. Kaso COPD tayo, buong lung natin hindi oxygenated. Kaso medyo bopals yung adaptation na yun, magva-vasoconstrict lahat, buong pulmonary vasculature that will lead to pulmonary hypertension. Okay? So, diffuse interstitial fibrosis, medyo ganun din, no? Medyo ganun din yung mechanism. Okay? Diseases of the pulmonary vessels, primary pulmonary vessel disease. For instance, you have recurrent thromboembolism, okay? That can cause global vasoconstriction of your pulmonary vasculature leading to pulmonary hypertension. And of course, your primary pulmonary hypertension. Okay? Diseases affecting the chest movement. Okay? Usually, actually, ito restrictive lung disease to, yung mga ganyan. No? Mga kyphoscoliosis, obesity. Okay? Usually, those are restrictive lung disease. Hindi makapag-expand fully yung lungs natin. Ganun din, no? That will still increase your pulmonary pressures. Okay? Now, diseases causing pulmonary vascular constriction, obstructive sleep apnea. Again, obstructive sleep apnea, hindi ka humihinga. No, habang tulog ka, hindi ka humihinga, your lungs are not oxygenated well. Ano nangyayari sa pulmonary vasculature sa lungs if it's not oxygenated well? Vasoconstrict, increased pulmonary pressure, hypertensive heart disease, right-sided. Okay? Okay. Valvular heart disease tayo. Again, so ito medyo hindi siya ganun ka-pathology, no, yung valvular heart disease natin, except for I think infective endocarditis, rheumatic heart disease. Actually hindi pa rin no. Pero let's just discuss yung mga possible etiologies, no, of your valvular heart disease. So mitral stenosis, no? Mitral stenosis usually can be from post-inflammatory scarring from your rheumatic heart disease. Rheumatic heart disease can also cause your aortic stenosis, no? Dito rin, no? Calcification of the mitral ring, pwedeng senile, pwedeng dahil sa pagtanda, no? Aortic stenosis, definitely senile, can cause your senile calcific aortic stenosis, no? Pagtanda natin. Pero may isang important cause of your aortic stenosis. That's your bicuspid aortic valve. Okay? Bicuspid aortic valve. So, bicuspid aortic valve, that is a congenitally deformed valve and that is more prone to calcification and can cause your aortic stenosis. Mitral regurgitation, madaming causes. Napag-usapan natin kanina yung papillary muscle rupture, no, in myocardial infarction that can cause acute mitral regurgitation. Okay? So again, post-inflammatory scarring, pwede din, no? Pwede din. From RHD, mitral valve prolapse can cause mitral regurgitation if meron tayong further degeneration. Excuse me. So, ayun. Aortic regurgitation can be caused by your intrinsic valvular disease. post-inflammatory scarring, no? Rheumatic heart disease. Basically, your rheumatic heart disease can cause everything. Can cause your every valvular heart disease. Okay? So, ayun, no? Infective endocarditis or endocarditis in general can present with regurgitations. No? So, infective endocarditis, your Liebman-Sachs endocarditis in lupus can present with various valvular heart disease. Okay? Okay, cardiomyopathies. Madali lang to. Tatlo. Think of three. Your your dilated, your hypertrophic, and your restrictive cardiomyopathy. So your dilated cardiomyopathy is your progressive cardiac dilatation and contractile systolic dysfunction. Madaming causes ng dilated cardiomyopathy. One is ischemia. Napag-usapan natin kanina. Hypertrophic cardiomyopathy, ventricular hypertrophy yan that will lead to defective diastolic filling and obstruction of your ventricular outflow tract. Pwedeng acquired yan, no? Pero when we discuss cardiomyopathies, especially your hypertrophic cardiomyopathy, we talk about the genetic causes, no? That's your hypertrophic obstructive cardiomyopathy. And the genetic cause, that is a very important, no? Very important buzzword for your boards, is your mutations in the beta-myosin heavy chains. Okay. Restrictive cardiomyopathies, usually disorders that increase the stiffness of your ventricular wall. Usually, yung mga infiltrative diseases, mga amyloidosis, mga deposition diseases, hemochromatosis, no? Pero actually, your hemochromatosis can causes dilated cardiomyopathy more than your restrictive cardiomyopathy. Okay? So, this is from Robbins, no? Dilated, hypertrophic, and restrictive, no? So, ganun din, no? Dilated, impaired yung ating systolic function. Kasi dilated na siya, no? Meron ka ng eccentric, no? When we say dilated cardiomyopathy, meron pa ring hypertrophy yan, no? Pero the hypertrophy is eccentric. So, stretched ang ating ventricular walls. Sa hypertrophic cardiomyopathy, the hypertrophy is concentric. So, thickened sila. No? Restrictive cardiomyopathy, again, yun yung mga infiltrative diseases natin, amyloidosis, yan, radiation-induced fibrosis, etc., etc. Okay? So, again, no, to reiterate, napag-usapan natin kanina kanina, before the start of the lecture. So, we will just focus on high yield points for this lecture, no? Okay, next is your congestive heart failure. Okay, congestive heart failure. Congestive heart failure can be left-sided heart failure, can be right-sided heart failure. What is the most common cause of right-sided heart failure? It's your left-sided heart failure. Okay, left-sided heart failure. Congestive heart failure is more extensively discussed in your internal medicine rather than uh, your pathology. Okay? So, yun na lang, no? Most common, no? Most common cause of your right-sided heart failure, left-sided heart failure. Cardiac tumors, no? Isa lang tatandaan nyo dito, most common cardiac tumor. It's your atrial myxoma. Okay? Now, move on na tayo from the heart and let's go to red blood cells. Okay? I think we're running out of time konti, no? So I would want to make this lecture still high yield and more still concise, no? So let's move on. No? Red blood cells, high yield sa red blood cells, anemia. Okay? Anemia. Now, we can classify your anemia according to the cause. Okay? Pwedeng blood loss, pwedeng impaired red cell production, pwedeng hemolytic anemia. So, in blood loss, again, pwedeng acute, no? Trauma, vehicular accidents in general. Chronic blood loss, no? So, GI pathology, gynecological pathologies, no? In males that present with anemia, kailangan natin ma-rule out ang GI losses, no? Or GI blood loss. Okay? Impaired red cell production. Okay, pwedeng decrease in proliferation of your stem cells, no, sa bone marrow, and that will cause aplastic anemia. So aplastic anemia usually that is associated with pancytopenia as well. Okay, decreased erythroblast proliferation is also a form of your impaired red blood cell production. So defective DNA synthesis. Pag defective yung DNA synthesis natin, for instance, meron kang vitamin B12 deficiency. We talk about this in biochem, no? Folic acid deficiency. Diba? So, hindi ka makakapag-synthesize ng nucleotides mo, particularly your thymine. Okay? Now, you have defective DNA synthesis, your red blood cell production will be impaired. Okay? So, imbis na yung cell division ng red blood cells would be complete, it will be stuck at one point, no? At one point. Every cell division ng red blood cells lumiliit siya. So pag na-stuck siya at one point, hindi naliliit to the mature red blood cell size yung red blood cell natin. That will cause megaloblastic anemia. Kaya megaloblastic ang vitamin B12 deficiency, kaya megaloblastic ang folic acid deficiency. Anong pinagkaiba nila? Vitamin B12 deficiency will present with neuropathy. Okay? That's your subacute combined degeneration. Alright? Defective hemoglobin synthesis. Okay? Thalassemias. Okay? Thalassemias and iron deficiency anemia. Okay? Thalassemia versus iron deficiency anemia, usually, you can differentiate that using your red blood cell indices. Iron deficiency anemia has increased red cell distribution with or RDW. Thalassemia has normal IDW. Pag hindi pa din, you compute your Menser's index. Okay? Less than 13, thalassemia. More than 13, iron deficiency anemia. Pero, definitive pa rin, you do iron studies. Okay? Miscellaneous, anemia of chronic disease, anemia of chronic kidney disease, decrease in your erythropoietin production that will cause decrease in erythroblast proliferation, impaired red blood cell production, anemia. Anemia can be seen as early as stage 3 CKD, okay? But almost universally present at stage 4. Okay? Myelocytic anemia, ano yan? That's the infiltration of your bone marrow by tumor cells, fibrosis, and other etiologies na mai-infiltrate yung bone marrow. So, kapag nagkaroon ka ng infiltration of the bone marrow, magkakaroon ka ng decreased erythropoiesis. Actually, this is also accompanied by your pancytopenia. Okay? In hemolytic anemias, no, we can classify them as intracorpuscular or extracorpuscular. Kapag intracorpuscular, the problem lies within the red blood cell. Kapag extracorpuscular, the problem lies outside the red blood cell. Okay? In intracorpuscular, acquired, isa lang yan, paroxysmal nocturnal hemoglobinuria. Okay, we discussed this earlier. Actually, previous sessions natin, this is caused by the mutation of your CD55 and CD59. Usually, the treatment of choice is your eculizumab. Okay? Pag hindi gumana si eculizumab, you do your pegcetacoplan. Okay? Pegcetacoplan. Bago lang yon, no? Okay? So, intracorpuscular, usually hereditary. Acquired, isa lang yan, PNH. Okay? PNH. Now, hereditary, pwedeng red blood cell membrane defect, enzyme defect, or hemoglobin synthesis defect. So, nandito pa rin si thalassemia sa hemoglobin synthesis defect. Sa membrane defects, no, hereditary spherocytosis, no, hereditary spherocytosis. How would you diagnose your hereditary spherocytosis? You do your osmotic fragility testing. Okay, osmotic fragility testing. Okay, RBC enzyme defect, G6PD deficiency. We discussed this sa previous biochem sessions natin. No, I will not reiterate no yung G6PD deficiency. Madali lang 'yan. Madali lang yung G6PD deficiency. Hexokinase deficiency, pyruvate kinase deficiency can also cause hemolytic anemia as well. Sige na nga, hindi ko mapigilan eh. Sige, G6PD deficiency. G6PD is the rate-limiting enzyme of your hexose monophosphate shunt. Ano ba yung dalawang products what are the major products of your hexose monophosphate shunt? So that's your ribose 5-phosphate sa DNA synthesis yan, and your DNA and RNA nucleotide synthesis, etc. No? And your NADPH. Wala na tayong pake dun sa ribose 5-phosphate. Sa NADPH, madaming uses ang NADPH. Fatty acid synthesis, steroid synthesis, regeneration of your reduced glutathione, and your oxidative burst. Okay? Oxidative burst. So, NADPH, ang focus natin sa regeneration of your reduced glutathione. NADPH is used by your glutathione reductase to form your reduced glutathione. So kapag wala kang NADPH because meron kang G6PD deficiency, you will have depletion of your reduced glutathione. So your red blood cells will be subjected to increased oxidative stress and then puputok, hemolytic anemia. Okay? So, ayun, no? Extracorpuscular infections, just like your malaria and hookworm. Wala tayong problema sa red blood cell per se. Kaso, pinasok ng infection eh. No? Usually malaria. I never heard of hookworm, infection causing your anemia. Okay? Pero malaria talaga. Okay? Other infections, babesia, Babesia microti can cause your hemolytic anemia. Okay? Antibody-mediated, di ba? Your autoimmune hemolytic anemias. Okay? Mechanical trauma, kapag meron kang thrombotic thrombocytopenic purpura, you have your DIC, consumptive coagulopathy, as well as your sequestration, pag meron kang hypersplenism. Okay? So, that's for your red blood cells. Let's move on to your white blood cells. So let's talk about leukemias and your lymphomas. Okay? We have different types of your leukemias. Ito, actually, dito mga non-Hodgkin to, no? Mga non-Hodgkin. B-cell, no? B-cell acute lymphoblastic lymphoma or B-ALL, no? B-ALL. Usually, that is caused by mutated genes, no? Pwede pa rin yung BCR-ABL, your Philadelphia chromosome, no? Pero usually, mga ABL tyrosine kinases talaga dito, no? Lymphoblastic to, no? Galing sa lymphocytes. Pag galing sa lymphocytes, walang Auer rods, no? Auer rods. Ano ba yung Auer rods? No? In your morphology, yung Auer rods, yun yung mga eosinophilic na rod-shaped stuff, sorry, no, sa cytoplasm ng cells natin, no, oo. So, that's from your myeloperoxidase. Myeloperoxidase. May myeloperoxidase ba sa lymphocytes? Wala. Sa lymphoblasts, wala, no? So, walang Auer rods kapag mga lymphoblastic. Okay? T-cell, syempre, from T-cells, no? Cells. T-cell acute lymphoblastic leukemia. Acute myeloid. Ayan, myeloid. Ang myeloid cells ba natin, merong myeloperoxidase? Meron. So, merong Auer rods. Okay, di ba? So, AML, may Auer rods yan. So, AML, kapag may Auer rods, ang tawag natin doon sa cell is your fagot cell. Okay? Kapag AML, no, yung mga leukemias that are associated with Auer rods, no, are particularly more at risk for DIC, no? Especially your acute promyelocytic leukemia or your APML. Okay? Anyway, meron pang iba, myelodysplastic syndromes, okay, chronic myeloid leukemias. Chronic myeloid leukemia, yun yung classic na merong Philadelphia chromosome, your BCR-ABL gene. Okay? Okay? So, ito, hindi naman to leukemias, no? Yung mga polycythemia vera. Tandaan lang natin sa polycythemia vera is yung EPO natin is normal. Okay? Compared to reactive polycythemia na mataas ang EPO. EPO is erythropoietin. Polycythemia vera, normal. Low to normal ang EPO. Kapag reactive polycythemia, mataas ang EPO. Kapag polycythemia vera, usually, meron tayong mutation sa JAK2 tyrosine kinase gene. Tapos, it can present with itchiness kapag nag-shower. That's your aquagenic pruritus. Okay? Primary myelofibrosis, no? So, pwedeng JAK2, MPL, no? MPL tyrosine kinase genes or CALR genes, no? Yung primary myelofibrosis. Usually, kapag primary myelofibrosis, diyan natin nakikita, textbook-wise, no? Textbook-wise, yung mga dacrocytes or your teardrop cells. Okay? So, here, no? Gusto ko mag-focus dun sa acute promyelocytic leukemia. Again, mataas ang propensity niya to cause your disseminated intravascular coagulation. But this is the only cancer that can be cured by a vitamin. What vitamin is that? That's your vitamin A, okay? In the form of your ATRA or your all-trans retinoic acid, okay? All-trans retinoic acid. So, yun, no? That's the only cancer that can be cured by your vitamin. So, this is your FAB classification for your AML. For me, this is only nice to know, pero we'll never know, di ba? We'll never know. So, might as well go through this. Okay? So, general features of your acute leukemia, usually acute, so rapid onset, no? Leukemia, usually, unang presentation niyan is pallor, anemia, no? Anemia, weakness. Okay? It can also present with thrombocytopenia. Okay? Ang dami mong leukocytes pero immature yan, hindi yan nag-function well, bopples na leukocytes yan, you will have frequent infections. Okay? Hepatosplenomegaly, because you will have leukemic infiltration. Okay? So, yun. So, meron tayong mga oncologic emergencies that can be the first sign of your leukemia. For instance, an elderly patient na nagkakaroon ka ng priapism, no? Priapism or DIC, okay? DIC again. Usually mga ano yan, mga myeloid leukemias, yung mga magkakos ng DIC, especially your APML. Okay? APML. Leukostasis is more common in your AML. Okay? So, yon. ALL versus AML, usually mahirap sila i-differentiate by your clinical features alone, no? Pero, we have a entity called your leukemia cutis for your AML na meron kang skin lesions na nodular, na medyo purple to gray color. Tapos usually mga may gingival hyperplasia, yung mga may AML, no? Kapag ALL, usually yan yung mga may lymphadenopathies, no? Kasi nga lymphocytic, lymph nodes, diba? Bone pains, no? SVC syndrome kasi pwede ka magkaroon ng lymph node enlargement, especially sa cervical lymph nodes natin, etc., etc. Okay? Rare finding, no, sa ALL is your testicular enlargement. Okay? So, these are, no, ito yung mga this is actually non-Hodgkin, no? Non-Hodgkin lymphomas, no? Ang gusto ko dito i-emphasize is your follicular lymphoma, mantle cell lymphoma, and your Burkitt lymphoma. Okay? Follicular lymphoma, take note, for translocation 1418. Okay? Translocation 1418, must know. Okay? BCL2 yung affected. BCL2. Okay? Sa mantle cell lymphoma, translocation 1114. Okay? Translocation 1114. Must know. Okay? Cyclin D1 yung affected. Sa Burkitt lymphoma, translocation 814. Okay? Translocation 814. Ang ano natin dyan, ang oncogene natin yan is your c-MYC. Okay? C-MYC. Meron tayong tatlong klase ng MYC gene, MYC. No? Your c-MYC is for your Burkitt lymphoma. Your L-MYC is for your lung cancer. Your N-MYC is for your neuroblastoma. Okay? Burkitt lymphoma, morphology, starry sky appearance. Okay? Starry sky appearance. So, yan. In your Hodgkin lymphoma, what's important is that the most common Hodgkin lymphoma is your nodular sclerosis. the best prognosis is your lymphocyte rich, and the worst prognosis is your lymphocyte depletion. Mas madami kang lymphocytes, mas maganda ang prognosis. Usually, yung mga lymphocyte depletion, yun yung mga HIV associated. Okay? So, yan. Let's move on to our bleeding disorders. Okay? Bleeding disorders. So, bleeding disorders can be classified sa vascular fragility, platelet dysfunction, and your coagulation factor deficiencies. No? Vascular fragility, that's, for instance, vitamin C deficiency. Diba? Remember that your vitamin C is important in your collagen synthesis. How? Vitamin C, actually, indirectly, no? Indirectly lang. What's important in your collagen synthesis is your iron in the ferrous form. Okay? Iron in the ferrous form. Your vitamin C maintains your iron in the ferrous form. Okay? Kaya remember, di ba sa methemoglobinemia is yung hemoglobin natin, nagiging, imbis na yung iron niya, ferrous form, nagiging ferric form. Diba? So, in methemoglobinemia, ang binibigay natin, methylene blue and vitamin C. Okay? Kasi vitamin C is an antioxidant that maintains your iron in the ferrous form. And iron in the ferrous form is important in your collagen synthesis. And collagen is important in your blood vessels. Okay? Kapag sira ang collagen mo, pangit ang collagen mo, you will have brittle blood vessels, bleeding. Okay? Other causes na bleeding disorders due to vascular fragility is your systemic amyloidosis, chronic glucocorticoid use, connective tissue disorders, no? For instance, yung mga Ehlers-Danlos, Marfan's, ganyan, vasculitis. Okay, platelet dysfunction, of course, thrombocytopenia. So, thrombocytopenia, konti platelets mo, no? Qualitative defects, pangit yung platelets mo. So, that will cause bleeding. Usually, kapag platelet dysfunction ng bleeding, usually petechial yan. Okay? Petechial. So, important sa qualitative platelet dysfunction, no, is your uremia, no? Uremic platelet dysfunction. So, normal platelet number, pangit yung quality. Okay? Coagulation factor deficiencies. So, hemophilias. Hemophilia A is coagulation factor 8 deficiency. Hemophilia B is coagulation factor 9 deficiency. Hemophilia C, meron ba nun? Meron. Factor 11 deficiency. Okay? Underproduction, sige, vitamin K deficiency. So, vitamin K deficiency can cause underproduction of the coagulation factors 10, 9, 7, and 2. Those are your vitamin K dependent coagulation factors. Liver disease can also cause your coagulation factor deficiencies. No? The liver produces all coagulation factors except for your factor 8. Okay? Factor 8. Okay, so factor inhibitors, pwede rin, no? BIC pwede din. So usually, coagulation factor deficiencies, hemorrhages ang ating presentation. No? Compared sa platelet dysfunction na petechial bleeding. Alright? So again, no, na-discuss natin kanina, no, yung liver vitamin K deficiency kasi 10972, no, yung problema. Liver disease kasi the liver produces coagulation factors except for your factor 8. DIC is your consumptive coagulopathy, uubusin niya lahat ng coagulation factor mo, bleeding. Von Willebrand disease, di ba pang platelet yun? Paano naging coagulation? Von Willebrand disease, no? Teka, liver disease, di ba sabi ko, all coagulation factors except factor 8. Saan ba nasi-synthesize ang factor 8? In your endothelium, along with your von Willebrand factor. That's why von Willebrand disease can cause your relative factor 8 deficiency. That's why in your von Willebrand disease, hindi lang bleeding time yung affected. Affected din ang ating PTT. Kasi remember your factor 8 is in your intrinsic pathway, di ba, of your coagulation. Of course, hemophilias, we talked about this few minutes ago. So, this is your vitamin K deficiency and your hepatic dysfunction. No? Kapag vitamin K deficiency, your vitamin K, no? Okay, your vitamin K, or actually your reduced, no, vitamin K is important, no, important in your gamma glutamyl carboxylase enzyme that functions in the carboxylation of your factors 10972. Non-carboxylated 10972 coagulation factors are not active and thereby in will not be um, will not be active, no? Okay. Sige, liver cirrhosis, straightforward. Hindi ka nagpo-produce ng coagulation factors. So, wala kang coagulation factors, there's nothing to carboxylate bleeding. Okay? So, this is the mechanism of your disseminated intravascular coagulation. Okay? For instance, you have massive tissue destruction, trauma, okay? Sepsis, okay? Endothelial injury. This will cause, lahat sila magkakause ng release of your tissue factor. Tissue factor, remember, ang tissue factor ay sa extrinsic pathway, no? Didikit siya sa factor 7. Tapos, can trigger your extrinsic pathway of your coagulation. So, that will cause widespread microvascular thrombosis. Your endothelial injury can also produce platelet aggregation and will therefore cause widespread microvascular thrombosis. So, ano mangyayari kapag meron kang widespread microvascular thrombosis? Your plasmin will be activated, your fibrinolysis will be activated, okay? Pag magkaroon ka ng fibrinolysis, you will lyse your clotting factors, bleeding. Okay? Tapos, widespread microvascular thrombosis can also lead to vascular occlusion, leading to ischemic tissue damage. So, meron ka ding thrombus, no, sa blood vessels natin and can cause microangiopathic hemolytic anemia. And this thrombosis can also consume your clotting factors and platelets, kaya nga consumptive coagulopathy, bleeding. Alright? Let's move on sa spleen. Ito, mabilis lang to. No? Let's talk about splenomegaly. So, massive, moderate, and mild. So, in massive splenomegaly, ang weight niya is more than 1 kilo, no? More than 1,000 grams. Okay, usually caused by your myeloproliferative neoplasms, no? Mga neoplasms na to. Okay? Moderate splenomegaly, mga congestion. Okay? Mild splenomegaly, infectious mono. In infectious mono, no? EBV, we advise patients to avoid contact sports because of the risk of splenic rupture. Okay? Thymus, isa lang yung masasabi ko dito, thymoma. Okay? Thymoma is associated with your pure red cell aplasia and your myasthenia gravis. Okay? Now, let's move to the lung and pleura. Okay? So, let's first talk about your acute respiratory distress syndrome. Then, let's talk about obstructive lung disease, pulmonary infections, papiaw lung, and your lung tumors. Okay? Now, acute respiratory distress syndrome, this is the damage to alveoli throughout the lungs. Now, this will cause edema and eventually respiratory failure. So, what is the histologic manifestation of your acute respiratory distress syndrome? That is your diffuse alveolar damage. Okay, excuse me. So, this is a diagram, no, from Robbins of your acute respiratory distress syndrome, no, in acute lung injury. So, maganda siya basahin, no? Maganda siya basahin, although nilagay ko lang siya kasi makulay siya. So, ARDS, no? ARDS. So, we have a criteria for ARDS. This is known as your Berlin criteria. Okay? ARDS. So, acute dapat yung onset, dapat within 1 week of insult, no? Or new or worsening symptoms in the last 1 week. Acute, no? Kaya nga acute respiratory distress syndrome. So, we have to have bilateral opacities on chest imaging. Okay? We have to have a PiO2 FiO2 ratio of less than or equal to 300, mababa, while on PEEP more than 5. Okay? that is not fully attributed to cardiac failure or volume overload. So we can further classify yung ARDS, no, based on the oxygenation. Mild kapag 200, no, less than 300. Moderate kapag 100, less than 200. Okay, severe kapag less than 100. Okay? So, crash course, lung injuries, no? Acute respiratory failure, types 1 to 4. Type 1, hypoxic. Okay? Hypoxemic. Type 1, hypoxemic. Wala kang oxygen. Type 2, hypercapnic. Madami kang carbon dioxide. Type 3, associated with operations or peri-operative respiratory failure. Yung mga atelectasis natin. Type 4, associated with shock. Okay? Shock. Bakit? Your diaphragm will be hypoperfused, then hindi tayo makahinga. Okay, let's talk about obstructive lung diseases. So, important obstructive lung diseases natin would be your COPD. Ang umbrella of your COPD is your chronic bronchitis and your emphysema. Asthma is a obstructive lung disease, and recently bronchiectasis also an obstructive lung disease. Okay? Now, let's talk about asthma. No, this is from GINA guidelines. No, mabilis lang, no? Your asthma is kailangan, no? It is an obstructive lung disease, pero it is supposed to be reversible, no? How would you document the reversibility? Okay? Usually spirometry, no? We have to do spirometry. So, we have to have, no, a more than 12% increase, no, of your FEV1, um, and more than 200 ml increase in your volume. Hindi or and after bronchodilator. Okay? So, yun yung reversibility natin sa asthma. Or, meron tayong reversibility after a trial, no, 4-week trial of your oral corticosteroids. Okay? So, nilagay ko lang dito yung GINA guidelines for asthma. So, if you have symptoms less than twice a month, you go with step 1. You give a low dose ICS formoterol, no? That's Symbicort, no? Symbicort here in the Philippines. Okay, step 2, usually symptoms twice a month, okay? Or more, but less than daily. Okay? So, usually, magme-maintain ka na talaga dyan ng ICS formoterol and so on, no? Step up tayo. Okay? So, next is your COPD. Again, spirometry pa rin tayo in diagnosing COPD. So, pag obstructive lung disease, talaga, we have to have an FEV1 to FVC ratio of less than 0.7. Then, we have to classify by GOLD, no, sa COPD. More than or equal to 80, that's gold 1. More than equal to, 50 to 79, that's gold 2. 30 to 49, that's gold 3. Less than 30, that's gold 4. Then, we have to do assessment of symptoms and risk of exacerbations. Then, we have to note your exacerbation history, MMRC, etc. Then, we have to plot kung saan siya, kung A, B, C, or D. Because magmamatter dyan ang ating treatment. Group A, we can go by with a bronchodilator. Okay, Group C, we can go by with a LAMA. Group B, kailangan long-acting, no? Bronchodilator, LABA or LAMA. Group D, toxic, no? LAMA or LABA plus LABA or ICS plus LABA. Sa severe lang talaga tayo nagbibigay ng ICS, no? Or inhaled corticosteroids in COPD, as opposed to asthma, no, na ICS talaga agad, because of we are preventing infections, no, in COPD. Okay, speaking of infections, we have pulmonary infections. Okay, pulmonary infections. So, pulmonary infections, ang pinakamahalaga dito would still be your pneumonia and your TB. Okay, pneumonia and your TB. Okay? So, the most common cause or etiology of your community-acquired pneumonia would still be Streptococcus pneumoniae. Okay? Streptococcus pneumoniae. Paano pag sa AIDS patient? What's the most common cause of your community-acquired pneumonia? It's still Streptococcus pneumoniae. Okay? Hindi PCP ha, hindi PCP. PCP is an opportunistic pneumonia in your immunocompromised patient or sa mga patient na may um, acquired or innate, no? Defects, no? Pero hindi pa rin 'yun ang most common pneumonia in the immunocompromised. Strep pneumo pa din. Okay? So, ayun, ano pa ba masasabi ko sa slide na 'to? So, ayun, yun lang, no? Tuberculosis, this is a good, no, slide, no, for tuberculosis. So, usually, we start with primary infection, magkakaroon ka ng primary complex, no? Then, magkakaroon ka ng localized caseation, usually Gons complex, sa mid lang, Gons focus, no? Sa mid lang. Kapag Gons complex kasi, it's your Gons focus plus your lymph node. Okay? Then you can progress to progressive primary TB and magkaroon ng hematogenous dissemination and cause miliary TB, usually sa mga immunocompromised na yan. Or, yung primary complex mo, pwede mag-heal and can cause a scar, no? Scar, na nakikita sa x-ray, na usually kino-confirm natin via sputum studies or gene expert, no? Or pwede maging latent, no? Maging latent. So, latent lesions, pwede siya mag-reactivate, no? That's your secondary tuberculosis. So, pag secondary tuberculosis, usually sa apex na yan, no? That's your Simon's focus, no? Usually sa apex na yan. So, it can still progress, magkaroon ng hematogenous dissemination, magkaroon ng miliary TB. Okay? Lung tumors, last. Easy, no? Madali lang tandaan to. Of importance dito is yung apat nilang tumors. Okay? Your adenocarcinoma, your squamous cell carcinoma, your your small cell carcinoma, and your large cell carcinoma. Actually, hindi na masyado nating ginagamit yung term na large cell carcinoma. Anyway, most common pa din, no, ay adenocarcinoma. Even in non-smokers, even in women. Okay? Adenocarcinoma pa din. Kapag sa smokers, you think squamous cell carcinoma and your small cell carcinoma. Ano yung paraneoplastic syndrome natin for squamous cell carcinoma? That's your hypercalcemia. Okay? Hypercalcemia. Bakit siya magkakaroon ng hypercalcemia? Because of your PTHrP or PTH-related peptide production. No? Usually sa squamous cell carcinoma yon. As opposed sa lymphomas na magkakaroon ka ng endogenous vitamin D production. No? Yun yung sa mga lymphomas natin. Small cell carcinomas, we have important paraneoplastic syndromes. No? Your syndrome of inappropriate ADH secretion or SIADH. No? We have your Lambert-Eaton myasthenic syndrome, and we have your Cushing's. So, yun yung classic paraneoplastic syndrome sa small cell carcinoma natin. Okay? Large cell carcinoma, usually kapag talagang wala no? Wala ka na, hindi mo siya ma-classify into adeno, squamous, or small cell, usually large cell na yan, or anaplastic, or adenosquamous, mga ganun. Okay? And I believe that ends our Genesis pathology. Alright? Aral mabuti and see you next time.